Hello, Karen. I'm reporting on the patient in room 305. The patient, Justine Sowers, is a 16-year-old male who was admitted today, April 15th. Today's his first day in the hospital. Mr. Sowers was admitted from the ER to the med-surg unit for hypoglycemia. Mr. Sowers is a full code and has no known allergies. He has type 1 diabetes and has an insulin pump that is worn continuously except during sports practice and games. The patient arrived via ambulance to the ER after he passed out during basketball practice. The patient stated he had blurry vision and dizziness that worsened over the practice, but tried to push through it. Mr. Sowers passed out during the practice and stated he woke up in the ambulance and couldn't remember anything. The patient stated he forgot to take his protein bar and energy drink prior to practice. The patient always makes sure he takes the snack, but stated he forgot this time. Mr. Sowers stated that he was diagnosed with type 1 diabetes 4 years ago and that he usually is very cautious about checking his blood sugar and making sure to eat the snacks before and during practice. However, he stated this time he just simply forgot it at home. The patient stated he has never passed out like this before. The patient has been improving from the time he was admitted. His symptoms have been improving. On initial assessment, however, the patient was A&O times 3 and was confused as to why he was in the hospital. The patient was anxious, sad, distressed, and crying. The patient stated he had a headache and felt very nervous and shaky. The patient had weak grip strength in both upper extremities and also had a bounding bilateral radial pulse. And he also had an increased heart rate. The patient complained of heart palpitations as well. However, he had bilateral clear breath sounds. Mr. Sowers stated he felt dizzy and he had an unsteady gait. Mr. Sowers was diaphoretic and had cool and clammy skin. However, Mr. Sowers reported no pain. He just explained that he was really tired and he seemed very lethargic. The patient had a fall risk score of 8 and fall precautions have been initiated and are still in place. The last vital signs that were taken were 30 minutes ago, and they were the following: blood pressure 107/74, oxygen sat 97, respiration 16, pulse 115, temperature 98.2, and no pain reported, as I have said. Mr. Sowers has been prescribed Lantus 45 units every morning. The patient also has a sliding scale coverage with regular Humulin insulin that is as follows. These are the sliding scale coverage. So 0 to 100, if that's the blood glucose level, it's 0 to 100, give 0 units, 101 to 200, give 3 units, 201 to 300, give 5 units, 301 to 400, give 7 units, and 401 or more, give 12 units. And if you give 12 units, make sure that you call the MD as well. The patient also has a diabetic standing order in place for hypoglycemia. So if the BGM is less than 60, give glucose 50 milligrams by mouth, either tabs or gel, and make sure to give him orange juice with peanut butter and crackers. If the BGM is less than 50, you need to give the dextrose 50 milligrams IV push over 5 minutes, and dextrose 5% and 0.9% sodium chloride at 100 milliliters per hour. Mr. Sowers was given the dextrose IV push when he was first admitted, and then the DVNS continuous infusion. However, it was recently discontinued because his blood glucose is now within normal range and is currently at 70. So those were admitted because he did have a blood glucose that was less than 50. He had 43 on admission. So those interventions were put in place, and if it does drop to that level, you should also be aware of those standing orders. But now his blood glucose is currently within the normal range. The DVT interventions also have been initiated for this patient. Also, in addition, the patient was also previously given glucagon 1 milligram IM once on admission. The patient has no additional oxygen, drains, or wounds that need to be taken care of. The patient has been on bed rest with bathroom privileges. The BGMs have been checked every 4 hours. I've encouraged the patient to drink more fluids and have re-educated him on the importance of balancing adequate exercise, carbohydrates, hydration, and adequate blood glucose monitoring. The patient has been helping physical therapy has been helping Mr. Sowers strengthen his mobility. The patient's glucose check on admission was 43, like I said. So we just need to be aware because it could potentially drop again. The patient also had an A1C hemoglobin done, and it was 7%, confirming his type 1 diabetes, as the patient has already been aware of and has been diagnosed with. The patient also had an insulin lab taken that was 250, indicating a high level from not having the adequate glucose in his blood. The patient has a Braden score of 19. The patient had a Glasgow score of 14, and the patient also has an 18 gauge IV in his right forearm for the medications. And it's been maintained, and it has been free of any signs of infection or infiltration or anything like that. The patient is on a 1,200 calorie ADA diet with increased fluids and has been tolerating it well. Dietary has worked with this patient on the best carbohydrate snacks to eat and the importance of intaking a carb and sugary drink instead of a protein bar and energy drink like he had been taking before practice. So dietary is working really closely with this patient to educate the parent and the patient on the best selection of snacks and meals. So re-educating the patient on that and making sure he understands would be really beneficial. So the patient has an admission diagnosis of hypoglycemia related to Mr. Sowers' confirmed previous diagnosis of type 1 diabetes. I am concerned about the patient's blood glucose level dropping to a low level again. It is currently 70, and the patient's signs and symptoms are improving from the medications and adequate nutrition. I'm also concerned about the patient's fall risk because his score is high and he still has an unsteady gait. I'm also concerned about the patient's knowledge of correct carbohydrate snacks and meals, adequate hydration, and exercise to prevent this from happening again. So those are just some of the concerns that I had. I recommend that you continue to do blood glucose monitoring checks every 4 hours and closely observe the patient for any significant change in those levels. The patient's condition can become life-threatening if the blood glucose is not adequately maintained at a normal level. Timely intervention of medications are essential, so please strictly monitor the patient's blood glucose. I recommend that you continue to initiate fall precautions as well until the patient has regained his full strength and has a steady gait during ambulation. Collaborate with physical therapy more as well to help increase his strength. I recommend you continue to work with dietary and help educate the patient on the best snacks and meals and timely intervention of these snacks and meals to prevent this episode of hypoglycemia from happening again. Educate the patient on the importance of adequate hydration and educate that prolonged or excessive exercise can lead to hypoglycemia. So it's very important that he follows a strict diabetic diet with several snacks before and during practice or games. Collaborate with social services for discharge as ordered by the MD. Continue to educate and teach the patient about the drug regimen and educate the patient on the importance of this and adhering to this. Strictly monitor the BGMs for any indication of the MD orders related to episodes of hypo or hyperglycemia. Continue to educate the patient on the pathophysiology of the disease and how it works to help him ease his anxiety and to help him become more aware of how he can monitor the signs and if he feels like a hypoglycemic if he feels like he's going into a hypoglycemic state. So just educating him on the importance and the signs and symptoms and how he can monitor his disease, his illness better. And just educating him on how he can prevent episodes like this, because if interventions aren't implemented soon, or if he's not treated in a timely manner, this can lead to life-threatening conditions. So just educate the patient on being aware of when he feels he is having a hypoglycemic, if he's in that state. And finally, just educate and assess the patient's psychosocial status. This is a very scary, and like he stated, very embarrassing, it may be embarrassing for him. So just educate his psychosocial status and make sure that he understands the plan for him, and that he agrees with it and he will tolerate it. Do you have any questions? No? Okay. Thank you so much.